Hello, everyone. Welcome to our Zoom meeting. Today, we'll have different items in the agenda that we will cover. And I pass it to you. When you are ready, you can start. Thank you.
The presentation, Dr. Einas.
Hello. Hello, can you hear me?
Yes.
Yes. Hello, everyone. My name is Malaz. I am the team leader of TAN1 team. I will be the moderator for today's meeting. Our agenda for today are going to be chronic obstructive pulmonology disease. Topic number 2 is going to be basic graphic design principle for medical posters and presentations. The fourth topic is going to be ZOLL heart failure management system and how it works. And the fourth topic is going to be continuous glucose monitoring, which will be presented by Dr. Layla. The first topic will be presented by Dr. Einas. Dr. Einas, are you with us?
Dr. Einas and Dr. Yusra.
Dr. Einas is fixing her microphone.
I can present if there is any issue. I can start my presentation.
Okay. Okay, we can start with Dr. Layla.
Okay. Hello, everyone. My name is Layla Ali, and thank you for giving me this opportunity to participate today. Before I start, I would like to express my gratitude to Dr. Nadir. Thank you very much for your time and support. And today I will be presenting a topic about continuous glucose monitoring. I will go ahead and share my screen right now. Just give me a second. I don't know if it's clear.
Yes, it's clear. We can see.
Okay. Okay. Continuous glucose monitoring in older adults. Okay, just give me a second, sorry. Okay, continuous glucose monitoring in older adults. And in introduction, diabetes is highly prevalent among older adults, and its management is complex. Traditionally, we rely on finger stick glucose testing, which provides only a few data points each day and can be painful or inconvenient. Continuous glucose monitoring or CGM, offers a new opportunity by providing real-time glucose data. This is especially important in geriatric, where hypoglycemia can be dangerous and often goes unnoticed. Okay, what is CGM? CGM is involve a small sensor placed under the skin, which measure glucose in the interstitial fluid. The sensor transmits this information to a receiver or smartphone, updating glucose level every few minutes. CGM can provide trends arrow, alerts for high and low glucose, and even detailed report for patient and clinicians. This helps us see the bigger picture of glucose pattern rather than isolated finger stick readings. Here we can see a sensor inserted in the upper arm, which is a common site for insertion. CGM sensor insertion site. This table shows different sites for insertions, plus the pros and cons of each site. Abdomen is easily accessed, stable readings, but closing interference is possible. Upper arm is comfortable, less interference, but it's harder to reach. And thigh is useful if abdomen and arm are unavailable, slightly less accurate, or also pressure discomfort could be an issue. And when we choose a site for the insertion, it should have sufficient subcutaneous fat. Besides, we should put also in consideration that some patient doesn't like the sensor to appear or be visible for others. So they choose to be in the abdomen or in the back, and so on. The thigh is usually used in pediatric patients. Area to avoid over scar tissue, tattoos, moles, or inflamed skin. Near bony prominence, area exposed to tight clothing that may dislodge the sensor, site with lipohypertrophy from frequent insulin injections. Here also we can see a sensor, elderly lady scanning her sensor with a smartphone. And here it shows how it appears in the screen of the smartphone. Here the reading is 96. The blood glucose reading is 96. And there is a graph also showing the fluctuation of blood sugar below. And this also is more clear. Here shows that the blood sugar is 112 milligram per deciliter. And the arrow beside the reading is pointing upward, indicating that the blood sugar is still increasing. When the point is pointing straight, that means the blood sugar is stable or it's steady. And if it's pointing downward, indicating that the blood sugar is still decreasing. Here also we can see the fluctuation of blood sugar down here. And this line indicates that whenever the blood sugar drop below this level, it will give alert to the patient or the device start beeping. Also, if it goes here above the 250 milligram per deciliter, then it will give also alarm for the patient. This is a small sensor, and this is a device called receiver, which is a small device that can also be scanned with the sensor, and it shows the patient's data as well. So the patient have the choice either to use his smartphone and download the app according to the type of the sensor, or use this small receiver, which will work the same way. Okay, we have here the value of CGM is that it tracks glucose level every few minutes and provide a comprehensive view of glucose change over time. It helps patient and provider see how food, activity, stress, and illness affect glucose level. It supports personalized diabetes management and better treatment decisions. Types of CGM. We have two types, real-time CGM and intermittently scanned CGM. Real-time provide continuous automatic glucose reading in real time. Sends alert for high or low glucose level. An example for that is Dexcom G6, G7, Freestyle Libre 3. The intermittent scanned continuous glucose monitoring, also called flash CGM, requires the user to scan the sensor with a reader or phone to get the glucose reading. Examples is Freestyle Libre 1 and 2. Okay, benefits in older adults. In older adults, CGM offers several benefits. It improves overall glycemic control and reduce hypoglycemia events, especially those that may occur overnight or without symptoms. It also reduces anxiety for both patient and caregivers, improve quality of life, and promote independence. Okay, CGM goals in geriatric patients. In the geriatric population, the primary goal of diabetes management is shifting from strict glucose control to ensuring safety, comfort, and individualized care. Continuous glucose monitoring (CGM) support this approach by minimizing the risk of hypoglycemia, which can lead to false cognitive decline and hospitalization. Instead of targeting aggressive hemoglobin A1C level, healthcare providers focus on maintaining a stable glucose pattern within a safe range that fit each patient overall health, functional status, and life expectancy. Okay, here's a question: can people without diabetes use CGM? And the answer is yes. CGM is primarily designed for people with diabetes, sometimes recommended for other conditions affected glucose, such as prediabetes, obesity, glycogen storage disease due to risk of low blood sugar, and also in insulinoma due to hypoglycemia. Challenges and limitations of CGM. Cost and insurance coverage may be a barrier. Technology use can be difficult for some older adults, may need caregiver support. Sensor insertion can cause discomfort or skin irritation. Large data volume requires proper interpretation, may overwhelm new users. And evidence from research. Research strongly supports CGM in older adults. Randomized control trial shows that it reduces hypoglycemia and improves A1C. For example, a study in a Journal of the American Medical Association found that older adults using CGM had significantly fewer severe hypoglycemia events compared to those using fingerstick monitoring. Overall, research suggests CGM is safe, effective, and well accepted in geriatric population. Here is a case example. A 72-year-old patient with type 2 diabetes experienced frequent hypoglycemia, leading to multiple ER visits. After starting CGM, he was able to recognize low glucose pattern earlier, avoid dangerous episodes, and reduce emergency visits. This case illustrates how CGM can improve safety, confidence, and overall management for older adults. Future directions. Looking ahead, CGM will play a great role in geriatric, especially with telemedicine. Clinicians can remotely monitor glucose pattern, adjust medication, and support patients without frequent clinic visits. Artificial intelligence is being developed to predict glucose trend and provide personalized alerts. Future device will be smaller, more affordable, and easier to use, making CGM accessible to a wider population. Okay, another future direction is integration with insulin pumps. Modern CGM are being integrated with insulin pump to form automated insulin delivery system. The CGM sends glucose data every few minutes to the pump, which automatically adjusts insulin delivery. This integration minimizes human error and reduces both hyperglycemia and hypoglycemic episodes. Non-invasive glucose monitoring. Researchers are developing non-invasive CGM systems that don't require a needle sensor. Promising approach include optical sensors. These are devices that use light instead of needles, like infrared light, to measure glucose level through the skin or other body fluid, like tears or saliva. Sweat-based biosensors detect glucose concentration in sweat using nanomaterials. Also, we have transdermal sensors, use low electric current to extract interstitial glucose through the skin. To summarize, CGM provides continuous real-time glucose data. In older adults, it improves safety, control, and quality of life. Challenges remain, especially cost and usability. With telemedicine and future innovation, CGM will become an essential tool to geriatric diabetes care. Here we have the references. And thank you everyone for your attention. If there is any question, I'll be more than happy to take.
Thank you very much, Dr. Layla, for
You're
your great
welcome.
presentation.
Thank you so much.
Thank you.
Thank you, Dr. Layla. This is an excellent presentation, and it's informative and up to date as far as what's going on in the future, so you can help your patients. I just want to add one thing. Can I just show you the screen here? So this is how it's done. So it comes as a basic tool that you put on the skin. So you prep the skin. Okay. And then you dry, and then you put the device. And it will stick, and then I think it's for a couple of weeks, and then you can use the device to read, or your iPhone or mobile phone. And this can be replaced, as I said, and then you can get a new one. And it depends on the insurance. Some insurance will cover. So, any questions?
Thank you, Dr. Nadir, for adding this video. It's very informative. Thank you very much.
You're welcome. Thank you for your great presentation again. And
Okay.
we can move on to the next item.
Thank you, Dr. Layla. Our next presenter is going to be Dr. Einas. She's going to present chronic obstructive pulmonology disease.
Hello, everyone. Is my voice clear?
Yes, we can hear you.
Yes, I apologize for the technical issue that happened. This topic will be represented by me and my colleague, Dr. Yusra. Okay, so she's going to start, and then I'm going to finish from where she starts, from where she ends. Dr. Yusra?
Yes, hello.
Okay. Can you see the screen?
Okay. Okay, so my name is Dr. Yusra Raafat. And first of all, thank you, Dr. for your support. And I'm pleased to welcome all of you to this focused presentation on chronic obstructive pulmonary disease in the older adult. As IMG is integrated in the healthcare system, it's important to appreciate the management of chronic disease like COPD, especially in the geriatric population, where the presentation can be typical and the management is complex. So in this session, we will review the core concept of COPD, highlighting the unique challenge and the best practice in treating seniors. So our session today will focus to cover the fundamentals of COPD, and then we will dive into the specific consideration of the older adult, including subtle presentation, diagnostic tools, and the key elements of the management, both pharmacological and non-pharmacological. First of all, let's start with the definition of COPD. The COPD is a common preventable disease, and it's a treatable disease characterized by persistent respiratory symptoms and airflow limitation that is not fully reversible. And the pathophysiology of COPD is divided into two. Chronic bronchitis, which cause cough and sputum, and emphysema, which reduce the lung elastic recoil surface area for the gas exchange. The gold standard diagnosis of COPD by use of spirometry, the post-bronchodilator forced expiratory volume in the first second divided by forced vital capacity. Okay, and the other slide. The prevalence of COPD is increased with age, and about 1 in 7 old adults over 60 have the disease. And it's a major cause of morbidity, mortality, and healthcare utilization, like hospitalization. The risk factor. The primary risk factor of COPD is tobacco smoking. 80 to 90% of cases of COPD is caused by tobacco smoking. But when we suspect patient to have COPD, and when we take the history from the patient, we have to ask about the occupational and environmental exposure, like dust, chemicals, and fuel smoke. And in the geriatric population, aging lung, normal age-related change, like reduced elastic recoil and weakening of the respiratory muscle may exacerbate the effect of COPD on the patient. Also, the undiagnosed disease in geriatric population, the symptoms often attributed to getting older and deconditioning. Okay. Now we will talk about the symptoms of COPD. The typical symptoms of COPD is chronic productive cough, progressive dyspnea or shortness of breath, wheezing, and chest tightness. But the seniors or geriatric population may not present with a significant cough or sputum. Instead, they commonly report non-specific symptoms like fatigue or gradual reduction in their ability to perform daily tasks, which is more commonly attributed to the age. Okay, and we have to be aware of the deconditioning trap. When an older patient says they cannot walk so far, we don't just assume deconditioning. We have to think about underlying pulmonary cause like COPD and heart failure. These require high index of suspicion. Okay, now we will talk about physical examination finding. We have general finding, chest finding, and extremities finding. The general finding of COPD is a use of accessory muscle of respiration and pursed lip breathing, cachexia, and underweight. And these general symptoms most likely indicate severe disease. The chest finding, which is the parallel chest, indicated by increase anterior-posterior diameter and decrease in the breath sound, and prolonged expiratory phase, which is often audible wheezing. Other finding, sign of right side heart failure or pulmonal, like peripheral edema, jugular venous distension, especially in chronic bronchitis and blue bladders. And we have central and peripheral and cyanosis. Now we will talk about the importance of spirometry in the diagnosis of COPD. The technique of spirometry is maximal inspiration followed by forced and complete expiration. And the spirometry is the gold standard and is mandatory to confirm the diagnosis in COPD in any patient with chronic symptoms and or history of risk factor exposure. The post-bronchodilator forced expiratory volume 1 divided by forced vital capacity less than 0.7 confirm fixed airway limitation. But in geriatric population, we have challenge like poor technique. Older people may struggle to perform the maneuver correctly. Maximal inspiration, forceful and complete expiration. And the alternative interpretation in the age-related lung challenge can lower the normal ratio, making the fix less than 0.7, potentially overdiagnosed. The action we have to do to ensure the quality control of spirometry result and repeat the test if the patient effort is poor. Now we will talk about the differential diagnosis of COPD. First of all, asthma. The symptoms of asthma are reversible and is a variable, and it's reversible by the use of bronchodilator, and the onset of asthma usually earlier in life. Number two, we have congestive heart failure. Chest X-ray, in the congestive heart failure, the chest X-ray show cardiomegaly and pulmonary edema beside elevated BMP and low BMP. Number three of the differential diagnosis, we have bronchiectasis. The patient present with a large volume of alert sputum, and the diagnosis of bronchiectasis is confirmed by CT scan, which show trunk lines and signal train sign. The other test we have to do is the chest X-ray and CT scan to evaluate for hyperinflation and interstitial lung disease and the lung cancer, which has a higher incidence in COPD patients. Also, we have to do alpha-1 antitrypsin deficiency screening, especially younger patient who is under 45 years of age, and those with minimal smoking history and lobular emphysema. Now we will talk about the severity of assessing severity of COPD by the GOLD classification. We have to use this classification because we need to treat the patient according to their symptoms. The GOLD classification of COPD have two classification. Classification number 1 is 1, 2, 3, 4 classification, which depend on the effective, on the forced expiratory volume 1, and this classification is used for diagnosis, and it's depend on the spirometry. And the other classification is the ABCD classification. It's used for the therapy, and it's depend on the symptoms. Okay, first of all, we will talk about the 1, 2, 3, 4 GOLD classification. As we mentioned, it's depend on the FEV1 in comparison to the normal population. Simply, we have three numbers: 80% of the predicted, 50% of the predicted, and 30% of the predicted. If the patient has FEV1 more than 80% of the predicted, this is classification number 1. And if the patient has predicted between 50% and 80%, this is number 2. If between 30% and 50%, this is number 3. If less than 30%, this is number 4 of the classification. The other classification is the ABCD classification, which depend on 2. Number 1, exacerbation and hospitalization, and which cause the symptoms. Okay. So if the patient has 0 to 1 exacerbation, this is class A and B. And if the patient has 2 or more exacerbation, this is class C and D. And if the patient has no hospitalization, this is A and B. And if the patient has admission in their life due to the COPD, this is class C and D. Okay, so we ask the patient when was the last time in the hospital due to the COPD. So it's depend on the history, how many exacerbation he has, how many hospitalization, and what caused this exacerbation. The previous slide, please. The previous slide.
Regarding, this is slide
The
number.
gold. No, slide number 9. Okay. So I will repeat what I said. So the severity of airway limitation according to the gold grade, symptoms and risk factor of the exacerbation, based on the post-bronchial FEV1 and based on the symptoms. So gold 1 is a mild, and in the gold 1, the FEV1 is 80% of the predicted in comparison to the general population. And group A is the group with the low risk and few symptoms. The gold 2 is the moderate. The FEV1 is between more than 50% and less than 80% of the predicted. And group B is the low risk and high symptoms. The gold 3 is the severe. The FEV1 is the more than or equal to 30%, and it's less than 50% of the predicted. And group C, the high risk and few symptoms. The gold 4, very severe. The FEV1 is less than 30% of the predicted. And group D is the high risk, high symptoms, the most common presentation for an older, newly diagnosed patient in the hospital. Okay. So now we will talk about the initial management. The most important intervention for patient with COPD is smoking. Stop smoking. This is the only way to slow a rate of the decline.
Dr. Yusra?
Yeah,
I apologize for something. It's just that the slides here, there is something about the slides that I did not fix here. I did not send it to you. It's just that the gold classification currently, it's group A, B, and E. This is my mistake. Okay, so the group E is the one regarding the high risk and high symptoms. Okay, these are the ones who have like more exacerbations and has more severity in the symptoms. Okay, and then we have group A and B. Okay, so I fixed this in this slide here, the gold group assessment. So we have here A, B, and E. So apologize for the mistake.
The initial
I can
management slide
from here.
Okay.
Okay. Okay. Thank you, Dr. Yusra. Thank you so much, and thank you, Dr. Nader, for this opportunity. We're very happy to be here. So I'm going to continue from here regarding the gold classification. So as my colleague Yusra has mentioned, we have group the gold 1, 2, 3, and 4. Okay, this is dividing it according to the fourth expiratory volume and the first second. Okay, regarding here the MRC that my colleague Yusra has mentioned here in this slide. Okay, here. So the MRC, according to the symptoms, this is a more like a questionnaire that you ask the patients. We have grade 0 to grade 4. So grade 0 is when the patient can only get breathless without strenuous exercise. Then grade 1 is when the patient gets short of breath when they're hurrying on the level or walking up a slight hill. Grade 2 is when patient walks slower than other people who are of the same age as that person. And then grade 3 is when they stop for breath after walking about 100 meters or after a few minutes on the level. And grade 4 is when they're too breathless to leave the house or they're breathless when dressing or undressing. I think this is regarding the modified MRC dyspnea scoring. Okay. Regarding the initial management, so here, regarding the pharmacological management, the most important thing here that we have is smoking cessation. So the management of COPD is dependent on these 4 pillars, these important 4 pillars. And smoking cessation is actually the priority and the number 1. Okay, it's the only intervention that is going to change the disease trajectory. Okay, it's not just the symptoms. And vaccinations are also really important because seniors with COPD, they are at high risk for severe illnesses from respiratory infections. That's why they should be up to date regarding all the vaccinations. The most important vaccinations, we have the influenza vaccine, pneumococcal vaccine, and then we have the COVID-19 vaccine. And pharmacotherapy is also guided by the ABCD group, or as I corrected, it's the ABE group, okay? And mainly it focuses on the bronchodilators, the LABA and LAMA. We have also the pulmonary rehabilitation. This is the cornerstone of non-pharmacological treatment, and this offers significant benefits to patients in terms of quality of life and exercise tolerance. Okay, this is the GOLD group assessment. We have A, B, and E. We have the exacerbations in the past year. Okay, so it depends on the exacerbations that has happened to the patient and the severity of symptoms. We have group A is when we have 0 or no exacerbations in the past year that had led to the patient being admitted to the hospital. We have group E, which is the number of exacerbations were 2 or more moderate exacerbations, or 1 or more time where they were admitted to the hospital. And then we have the severity of symptoms according to the MRC, dyspnea scale, and the CAT score. Whenever there is a severity in the dyspnea in group E, and adding to it the exacerbations that had happened, this is definitely group E. And then we have group A and B. It's only the severity of symptoms is what makes them apart. Okay, so we have here the dyspnea scale. When we have the score of 0 to 1, this is group A, but when it scores 2 or more, this is group B. Okay, regarding the pharmacological treatment, okay, we have group A, B, and E. In group A, most of them we're going to start with short-acting bronchodilators, which is the short-acting beta agonist or short-acting the SABA and SAMA, okay, a muscarinic antagonist as needed, okay. This is what we're going to start with. And the thing about it is that group A, this the SABA and SAMA, this is typically a young patient with mild airflow limitation and minimal symptoms. This is this is the group of people who we're going to use the SABA or SAMA with. Okay, and then for group B, we can add LABA or LAMA. Group B is when we have high symptoms, low risk. So we're going to use a combination of both the LAMA and the LABA. As for the geriatric consideration, what is better, if you're asked, is it the LAMA or the LABA? It's definitely the LAMA. Okay, due to the bronchodilator effect, and they have to use it only once daily. Another thing that we should take into consideration when treating seniors is polypharmacy. We want the most effective regimen with the fewest necessary doses, which often favors the LAMA-LABA fixed dose inhalers. Okay, as for group E, this is when we have frequent or severe exacerbations. So initial therapy options, we're going to use them both, the LAMA and LABA, or we can use the LABA plus inhaled corticosteroids if the eosinophils were more than 300 cells or the patient has a history of asthma or COPD overlap. Okay. Another thing that we should consider is that inhaled corticosteroids increase the risk of pneumonia. That's why if the patient has high risk of pneumonia, we're just going to avoid it completely and just focus on giving them a LAMA and LABA. This is just a summary for what we spoke about regarding the pharmacological management. So we have here group A, B, and E. Group A, we said we're going to start with the rescue medications. This is the SABA and SAMA. And then we have the LABA and LAMA, the long-acting beta agonist or the long-acting muscarinic antagonist. Group B, both combination, the combination therapy. And then group E, we're going to use it plus the inhaled corticosteroid if the patient has high levels of eosinophils or patient has asthma or overlapping COPD. Another thing that we should consider is that even if it was the best drug in the world, it's going to be useless if the patient doesn't know how to use it. Okay, so that's why it's really important to look at the inhaler technique that the seniors are using, because over here we have different devices that could be used. We have the pressurized, metered dose inhalers, we have the dry powder inhalers, the soft mist inhalers. These are all different kinds of dilators bronchodilators that we could use. So the most important thing is that we're going to use it accordingly. So if a patient has, for example, arthritis and they have poor gripping, okay, so the pressurized metered dose inhalers, these are going to be very difficult for them to use. Another thing is also the dry powder inhalers. This is going to be very difficult if a person has severe COPD or he has weakness. Okay, so why? Because this requires a very strong and fast inspiratory effort, which is going to be very difficult for these patients. So the kind of device that we're going to use is dependent on the patient themselves and the comorbidities that they have. And it's always important for us to observe the patient's technique. And we should treat poor technique as a management issue that needs to be corrected, and it's not a compliance problem. So these are the different types of inhalers that could be used. This is the pressurized metered dose inhalers. This is the most common one that you see more often. And then we have the soft mist inhalers and the dry powder inhalers. Now we have the non-pharmacological management, pulmonary rehabilitation. So pulmonary rehabilitation, this is the most effective non-pharmacological intervention. It's not just exercise, this is a multidisciplinary approach. So we have exercise training, we have disease education, nutritional counseling, and psychosocial support. This is very important for seniors because it does not only affect the lung function, but also it has an effect on their strength, their independence, their mental health, and their quality of life in general. The pulmonary rehabilitation program also reduces hospitalization and healthcare utilization. Okay, so it's always important to recommend this for all symptomatic patients, those who have moderate or severe diseases. And next one here, we have oxygen therapy and advanced interventions. So we have regarding the oxygen therapy, the long-term oxygen therapy has indications. So it's indicated if a patient's a partial pressure of oxygen is less than or equal to 55 millimercury, or the oxygen saturation is less than 88 at rest, or the oxygen saturation is 59 millimercury, or if the patient has cor pulmonale or polycythemia, and their oxygen saturation is less than or equal to 88%. The benefit for it is that if a patient uses it for more than 15 hours a day, it has shown to reduce mortality and improve pulmonary hypertension in patients with chronic hypoxemia. A critical clinical point is that during an acute exacerbation, we should be very cautious when we use high flow oxygen. Why? Because when we have high inspired oxygen, fraction of inspired oxygen, this is going to suppress the hypoxic drive and is going to worsen CO2 retention. And the target saturation over here is between 88 to 92%. We have also here comorbidities in older adults with COPD. The rule, not the exception, is that COPD patients, they do not only come with COPD alone. They usually have multiple comorbidities. And the link with cardiovascular disease is actually very strong. So we should not let the history of COPD stop us from using appropriate cardiac medications. Because even beta blockers, if you use the right beta blocker, it can also be good. Like the beta-1 selective beta blockers, these are actually safe and beneficial if the patient has cardiac indications, congestive heart failure, post-MI, okay? So we should not fear bronchospasm. Another thing that we should remember is the psychological toll. Why? Because chronic breathlessness causes profound anxiety, and we should always screen for and manage mental health issues as part of comprehensive care plan. Another thing that is also common is osteoporosis. This is due to inactivity, smoking, and recurrent use of oral corticosteroids. So screening and treatment are very necessary. So managing acute exacerbations. So exacerbations are a major cause of hospitalization and death in older adults. The diagnosis depends on the cardinal symptoms. If we have 2 or more present, especially like a purulence, consider bacterial infection. Okay, so we have here the Athanasian care criteria. This is according to the cardinal symptoms. We have increased dyspnea, increased sputum volume, increased sputum production. But core treatment is the bronchodilators. Usually we have the SABA, we have the albuterol and salbutamol. This is the initial treatment. And then we can use the systemic glucocorticoids for a short period of time, 5 days of oral prednisolone. This is standard to speed recovery. Also, antibiotics is indicated if we have 2 or more cardinal symptoms or if mechanical ventilation is required. But the most important thing that we should take care about is when used in geriatric population is that exacerbations, they might look like a confusion, increased fatigue, or change in mental status rather than the classic respiratory symptoms that we know. from dyspnea and wheeze and so on. So always suspected if the patient comes with confusion or fatigue or change in mental status. We have here also the antibiotic used in acute exacerbation COPD. So deciding when to use antibiotic is very important. Why? In order to limit antimicrobial resistance. So according to the previous criteria, we primarily treat when there is evidence of an active bacterial infection signaled by the sputum changes. And common pathogens are actually these respiratory bugs. We have the Haemophilus influenzae, Strep pneumoniae, and Moraxella catarrhalis. First line we're going to use is macrolides, and then second line we can use cephalosporins or doxycycline. And if it's complicated or severe, we can use the respiratory fluoroquinolones, levofloxacin, or augmentin. In order to prevent the exacerbation, the primary prevention is actually the foundational pillars that we've already discussed, from smoking cessation, vaccination, and using long-acting bronchodilators. However, we have advanced strategies for when we have frequent exacerbations. So when people are actually refractory, when the patients are refractory, like when we have the gold group E, okay, these are people who end up getting specialized therapies like roflumilast, and we have long-term azithromycin. Finally, we should also empower the patient and their caregiver. We should have a clear written COPD action plan. This allows them to act immediately at the first sign of trouble, and they would just go to the hospital and prevent the exacerbation. So this is the summary and key takeaways. We have high index of suspicion. We should always maintain a high index of suspicion. We should not just attribute shortness of breath to old age. Spirometry is your diagnostic tool. We should use the GOLD ABE system to guide therapy, keeping in mind that most seniors will start on dual bronchodilators. We're going to start immediately with the LAMA and LABA, and we should prioritize the patient-friendly care. We should check if they know how to use the inhaler, they have proper inhaler techniques, and we should simplify medications in order to prevent polypharmacy. And finally, remember the power of the multidisciplinary approach: smoking cessation, vaccines, pulmonary rehab. These are non-negotiable. Thank you for your attention. I'm very happy to take any questions that you have.
Thank you very much for your presentation, Dr. Einas and Dr. Yusra.
We have just a few questions
Okay.
to make this session a bit interactive. Dr. Yusra, do you want to start? Okay, I can start. We have here Mr. Chen. This is a 78-year-old former construction worker with a 40-year smoking history. He quit about 10 years ago, presents with a 6-month history of increasing fatigue and difficulty climbing stairs. He denies a bad cough or wheezing, stating he only clears his throat in the morning. He has no known cardiac history, and oxygen saturation is 94% on room air. So what do you think we should do? Should we prescribe a diuretic as the symptoms suggest early congestive heart failure? Or should we reassure the patients that his symptoms are due to deconditioning and recommend exercise? Or should we order post-bronchodilator spirometry to evaluate for fixed airflow limitation, or start inhaled corticosteroids and LABA immediately for suspected COPD? Any volunteer? An old patient came with a very long history of smoking, yet he quit 10 years ago. So what do you think we should do first?
I think the answer is C. Should do a spirometry.
Yes, very good. Let's see. We should always start with spirometry. Dr. Yusra?
Yes.
Okay, okay.
72 years old female diagnosed with COPD, gold grade 3, and FEV1 equal 45% of predicted. She reported MRC score of 3, stopped for the breath after 10 meters. She had three moderate COPD exacerbation requiring oral steroid in the past 12 months, according to the GOLD guideline. Which initial pharmacological regime is most appropriate for type D hen. She is high symptoms, MRC more than 2, and high risk 2 or more exacerbation. A, short-acting beta agonist as needed, long-acting muscarinic agonist plus long-acting beta agonist, inhaled corticosteroid monotherapy, LAMA monotherapy. What do you think? Anyone?
Dr. Yusra, I would
Combination
like
of
to drag your attention that people are answering in the chat box.
So the answer is a long-acting muscarinic agonist plus long-acting beta agonist.
We have the last question for today. We have Mr. Davis, 85-year-old male with known severe COPD on LAMA and LABA. His wife brings him in with increased confusion and a one-day history of increased cough with yellow-green sputum. He has mild peripheral edema, and the vitals, we have the respiratory rate is equals to 24, the heart rate equals to 105, and then the temperature is 38.2 degrees centigrade. Which is the most important initial in hospital treatment bundle? Is it starting high flow oxygen, sub-nebulizer, and IV fluids, or controlled oxygen with the target of oxygen saturation from 88 to 92%, sub-nebulizer, systemic corticosteroids, and empiric antibiotics? Or should we intubate immediately due to acute confusion and fever, or refer for emergency pulmonary rehabilitation and nutritional support? Does anyone have an answer?
I think the answer is B. Oxygen,
Yes.
SABA, corticosteroids, and empiric antibiotics.
Yes, very good. Okay. So thank you everyone for your time. We truly appreciate this. We appreciate the opportunity to present, and have a great day ahead. And good
Thank you,
night for
both of you.
people.
Thank you, Dr. Einas and Dr. Yusra.
Thank you, both of you. This is also a great presentation, and I hope this will help you in the future with your patients. Thank you.
Our next presenter is going to be Dr. Jamal. I'm going to share my screen now. Dr. Jamal, can you hear us?
Hello, everyone. How are you?
Hello, Dr. Jamal.
Am I audible?
Yes.
Okay. Now we will talk about the science of poster design. The first thing is using color and light to communicate effectively. And I'll give you that example. It's a good design and poster, and just have three color, the white and sky blue and the blue one. Next. Next, yes. Why good design matters. Your research deserves to be seen. A poorly designed poster can obscure even the most brilliant research. What's at stake? Lost engagement from key attendees, miscommunication of your hard work, reduced networking and collaboration opportunities. As we see, there's a lot of researchers give a good research with a high value, but with a bad poster. So we don't know about that one, and it never get be famous. Next. The power of color psychology. Color is not just decoration, it's a tool. The core concept is colors evoke emotional and physiological responses that can be leveraged in healthcare and scientific settings. And that's a three example. The red one is usually used for emergency and warning, and the green usually used for healing and something like that, and blue usually used for trust and calm, and that one. Next. Applying color mindfully. First one is do. Use limited palette, 2 to 3 main colors, as we see before, for a professional look. Ensure high contrast between text and background for readability. Mindful color design can improve the experience of a healthcare space, and that's an example. Small poster design with with 2 or 3 colors, and it's good mix. And don't do avoid overlay bright or clashing colors that cause strain. Don't rely on color alone to convey meaning. Think of color blindness. And we see that example, a design with the 3 colors, but it's not a good mix. And if you see that, you will think it's may a scam, and maybe just one wants to steal your money. And also, don't depend on just color. There's a patient have color blindness and can't differentiate the other color. Next. Foundational graphic design principles. Structure should guide the eye. Key principle is hierarchy. Make the most important information, title, and findings the largest. Contrast. Use size and color and weight to create visual interest and separation. Alignment. Line up text and image to create a clean, organized look. Proximity. Group related elements. A graph and its caption close together. Space. Use empty space to prevent clutter and give content room to breathe. Visual. A simple diagram illustrating each principle. That's a principle you have to make it, and I use that good, I think. Next. Typography, using the right font. If they can't read it, they won't read it. Font selection, and that's an example. Sans serif fonts, Arial and Calibri, Helvetica are clean, modern, and highly readable on screens and posters. Recommended for body text. Serif fonts like Times New Roman, Garamond can be used for titles to convey tradition and authority, but can be less readable at small sizes. Best practices: use a maximum of 2 different fonts. Title font, bold and large, 72. Headings, strong and clear, 36 up to 48. And body text, highly readable, 24 up to 32. Next. The poster layout blueprint, a roadmap for your readers. The logical flow, a poster should be easy to navigate intuitively. Standard column layout. A 3 or 4 column layout is often most effective. Guides the viewer's eye in a logical Z pattern or down columns. The key sections to include introduction, then methods, then results, then conclusion. Make it obvious. Don't forget acknowledgements and references and a QR code to your full paper. Next. And the presentation, be prepared. Prepare a 2 to 3 minute elevator pitch of your work. Anticipate questions and have answers ready. Engage your audience. Stand to the side and don't block your poster. Make eye contact and be enthusiastic. Have hands out or business cards available. And that's a presentation. If you will make a physical presentation, I don't think you can use it in online. Next. Synthesis, a checklist for success. Bring it all together. Final checklist. Just a few moments. Final checklist. Color. Is my color palette professional, accessible, and purposeful? Sorry, just a moment. The final checklist. First thing is color. You should ask yourself, is my color palette professional, accessible, and purposeful? And the light, is the flow logical and easy to follow? The typography, is all text large enough and easy to read from 5 feet away? Graphics, are my figures and charts clear and high resolution? Content, is the take-home message immediately obvious? Practice, have I rehearsed my summary? And that's an example of a checklist template. Next. I just gave you some tips and tricks, and if you want to discover this topic more, you have full references. A. Color in Healthcare, How Mindful Design Can Improve. B. Color Psychology Guide. C. Graphic Design Principles to Use for Your Next Poster. D. Which fonts to use on your scientific poster. E. preparing a poster presentation. F, tips on poster design and presentation. And thank you. Is there any question?
Thank you for excellent presentation. This is also very useful.
It's welcome.
Thank you, Dr. Jamal.
You're welcome.
I'll be presenting the next topic. Hello, everyone. My name is Malaz, and today we'll be talking about the ZOLL heart failure management system. It's a remote monitoring technology designed to detect early signs of fluid overload in heart failure patients. It helps clinicians act before the symptoms worsen. As you know, the heart failure is a major public health problem. It afflicts approximately 64 million people globally, and annually in the United States, more than 1 million patients are hospitalized with a primary diagnosis of heart failure. And by 2030, it is expected that more than 8 million people will be affected. Although significant developments have advanced in heart failure therapy, hospital readmission rates remain high at more than 50% within the first 6 months, with 24% occurring within the first 30 days after discharge. The ZOLL Medical is an American company that's best known for its defibrillators and cardiac support devices. Building on that expertise, they developed the heart failure management system that we're going to be talking about today to extend heart failure patient care and beyond the hospital into the home environment. Overview of the ZOLL heart failure management system. It's a non-invasive and wearable sensor system. I think the most important thing about it is that it's a non-invasive sensor. It continuously measures the thoracic impedance. It detects subtle changes in the fluid accumulation, and data are automatically transmitted to clinicians. The ZOLL heart failure management system is a remote patient monitoring platform that helps clinicians manage patients with chronic heart failure by tracking fluid status and physiological data daily and outside the hospital. This system uses thoracic impedance. What is thoracic impedance? It's an electrical measure that reflects how easily the electricity passes through the chest, or in simple terms, how much the electricity current is resisted by air or fluid in the chest. Air has a high impedance, which means it resists the current. On the other hand, fluid has low impedance, which means it lets the current pass easily. So if we have low thoracic impedance, this means that there's more fluid in the chest and the lungs are congested. This information will be helpful for us in the care of heart failure patients. The importance of remote monitoring. The traditional follow-up methods depend on symptoms such as dyspnea, orthopnea, weight changes, which typically manifests late in progression of the condition. It's important to recognize these symptoms and the pulmonary fluid before it turns into symptoms. It can build up before patients even notice them, and serving as an early warning sign of a potential heart failure decompensation event. The primary objective of implementing remote monitoring within heart failure management system is to prevent hospital readmissions and identify worsening heart failure at an early stage. The system has three main components. The patient wearable device, it's a sensor or a patch that captures impedance and physiological data. A home gateway a home gateway for data transfer, and a clinician portal that organizes the information into actionable insights. I'm going to describe how the heart failure management system works. First, the patient wears the sensor daily at home. Then the device will automatically send fluid and vital signs data to ZOLL's secure system. If the system detects increasing thoracic fluid, an alert appears on the clinician's dashboard. Then the care team contacts the patient for medication adjustment or evaluation. This flow allows near real-time tracking of each patient's fluid trends, which will make it possible for clinicians to intervene early. For example, if they want to adjust the diuretics before hospitalization becomes necessary for the patient. Clinical data from ZOLL's program show that the system helps identify deterioration earlier and supports evidence-based management, leading to fewer hospital readmissions and better patient stability. The outcomes are reduced readmission rates, earlier detection of decompensation episodes, improved adherence to heart failure management protocols, and better quality of life and cost savings. The evidence showed that every year about 1 million patients are hospitalized for heart failure in the United States, with nearly 1 out of 3 patients needing to return to the hospital within the first 3 months. A concurrent controlled clinical trial compared the utilizing of a wearable heart failure sensor for management following a heart failure hospitalization to the use of the usual care, which typically uses the patient's weight and symptoms. Subjects enrolled in the treatment arm of this study had 38% lower relative risk of rehospitalization after heart failure hospitalization, which is a huge difference. The system integrates easily into current workflows. It provides continuous visibility for the heart failure team and ensures early data-driven interventions. This proactive monitoring helps reduce or prevent costly readmissions and improves patient outcomes. It's best suited for recently discharged or high-risk heart failure patients. The data reviewed daily or per clinic protocol. Alerts prompt clinicians to contact or medication adjustment. It facilitates remote multidisciplinary management, and it makes the care for the patients more easy. In summary, the ZOLL system transforms heart failure management from reactive to proactive care. It provides data-driven heart failure care. It's non-invasive and continuous monitoring, detects fluid buildup early, which makes it makes the readmission preventable. By this technology, we can anticipate problems before they even occur, improving outcomes for both the patients and healthcare systems. Ultimately, it enhances patient quality of life by preventing the complications and minimizing hospital visits. It's proven to reduce readmissions and enhance the patient quality of life. Thank you, everyone. If anyone is interested in more details, here are some references. Thank you, Dr. Nader, for giving us this opportunity. We really appreciate it.
Thank you so much, Dr. Malaz, for a great, excellent presentation. Hopefully, this also will help some of your patients. Hospitalization and rehospitalization are very important topics in the US. So most of the hospitals will be fined if they have a lot of readmission. And to prevent that, there are a lot of studies to help patients, in this case, specifically patients with congestive heart failure. So this started a few years ago with monitoring, what they call remote monitoring. So they sent a patient with a scale and they ask them to keep track of their records like shortness of breath or difficulty walking and so on, and the weight log. So it will be transferred or shared with a center where they keep track of each patient. And if there is a significant weight increase or significant change in symptoms, then they will contact the primary care doctor, or a visiting nurse will see the patient and then they can adjust the medication. So the goal was to prevent the patient from going into heart failure exacerbation and visit the hospital and get more expensive care. So this is a new tool that can also be used in addition to the scale and remote monitoring. So the patient will help identify if there are some new symptoms, new findings, and hopefully they can be managed at home and stay home. So the quality of the life for these patients will be higher, readmission rate will be reduced or low. And this will help financial or like economy-wise for this hospital. Thank you so much, Dr. Malaz, for this great presentation. Thank you all.
Thank you,
Uh,
Dr. Nader.
Any questions for Dr. Malaz or any of the other presenters? If not, maybe we can move on to the next topic about updates, or if you have any ideas or fellows questions. Okay. I'm going to share with you this, just I found new information or pre-clinical courses that if you have some time, you can go to the app and click on these free courses. There are a lot of them. And it's in LinkedIn. You can start by doing one and you can add that to your CV, but hopefully it will help you. Some of them from NIH, other WHO, for example, and so on. So if you have time, I know you will be busy with your interviews and other things in your life, but it should help you, like Harvard online course for fundamental files. For example, if you put something like that in your CV, it will help you sell yourself better. And again, just a reminder, if you want to apply this year, please add yourself to the social media like LinkedIn, Facebook, or any other places. Add your photo and some information about your achievements. Maybe if you are in the US, also mention that if you have citizenship, green card, so that if programs look at your page, they will consider you for interviews and so on. Thank you. Any questions or any comments?
Thank you, Dr. Nader.
Thank you so much. So one final thing, if you have a minute, and I want to share with you. Today we talked about COPD, and it seems like it's an important topic, and the presentation was very useful. So I was thinking if any of you had an opportunity to develop an app a mobile application for your patients, that's well and good. But let's say if you want to develop a new app for patients with COPD, I started with a spreadsheet that I can share with you, and I need your help now. I'm gonna send it in the chat. So this is a link for Google document. Let's do this together. If you have a minute, maybe you can just add your name and what you want to do or to help me with. So here are some roles you want to provide, or you want to, let's say I came up with a new idea. You just put yourself and your email, and maybe you can help me develop the app. Or maybe you are not interested right now, but in the future, maybe you will have some time to promote it, or you will have some time to test the app and also provide some feedback. So if you want to do that, please go ahead. Or if you have some ideas right now, and I'm gonna show you, let's do the prompting. Let's try to use Canva. And let's do this. Stop here. So I'm gonna show you how we can do this together. So if we go to Canva and hit on Canva AI and then code with me. Then we can create a prompt, let's say create mobile for so so basically, let's say I create an app that for patients with COPD, and most of them will be all the others. So we can create this. In the meantime, it will create the app. If you want to add yourself in the list here, that would be great. If not, you are busy, that's also understandable. So when this is done, I'm going to show you. And if you want to, in the chat or in the sheet, if you want to tell us how you can help us improve this, for example. So if you have new ideas, if you want to use different colors, if you want to add more information to the patient as far as education, for example. So maybe it will help with that. So as you can see, it will have some sort of survey or some questions for the patient to identify, I think, how severe their symptoms are, and hopefully this will help. So this is the app. It's very simple. Medications, air quality appointment, and inhaler guide. And it will help also with breathing exercise. And this is a questionnaire. So some symptoms like shortness of breath, cough, energy level, and they can save a log. And you have any comments about this app here? Or if you want to add yourself as a contributor, testing, promoting this app, for example, we can share this. So I'm gonna use this in the design and present it as a website. So people or patients can log into this website and they can test it. So it's gonna be a shareable website. I'm gonna share it with you in a minute. So it will ask for URL or web address. So we'll try to get a simple web address. So instead of all this, but we'll just say COPD. And so we can copy this.
So I'm only going to wipe out the bottom of it again.
Now we can publish it. And people can test it and can see if there is any bugs or any. So we can copy and I can share it with you in the chat. So you can share this with your friends or other fellows, and hopefully it will help some of your patients. And if you want to help with increasing your, let's say you want to improve your CV, you can also add this to your CV that you are working on this app, or you can create similar app or different depending on what you see. So if you want to test it and find if there is problems with it, let's say if this is not working, then we will give another prompt to improve this. So if you want to see if this is working, for example, it's supposed to come here somewhere or save it somewhere. So I can go back and tell Canva that's not working. The symptoms log is not working. So it can redo it again, and saving the log will be displayed somewhere here. This is how the testing will be when you are developing a mobile app, and when you test it, you have to use it, then you can send it to your patients, and then they can use it and see if it's helpful. Any questions or any comments?
Yes, Dr. Nader, the application is very nice and it's very easy to make. Can we also add to it tracking the exacerbation and the severity of the symptoms? Because this is what could be actually avoidable.
Sure. So let's see. So I'm going to show you the screen again. Okay. So here's version 2, and this is the log. Hopefully it's going to work now. It's not showing the log when it's saved. It's supposed to save it. But you spoke about the exacerbation. What exactly you want to track? Let's say besides these symptoms, anything else you want to add specifically?
Can we add the MRC dyspnea scale, the one from 0 to 4? Like exactly, can we like be more specific about it and write like the symptoms and grade from grade 0 to grade 4?
Okay, let's see if they can add it. And it will calculate the severity depending on 2 or more, right? The score or the grade. This is great comment and nice idea or feature. So it will help patient understand the concept of exacerbation, and then maybe they can contact the doctor or the doctor can get in touch with them. So here we go. So they added the Disney score. Beautiful. Excellent. Any other comments or ideas?
We can also add if the patient has history of hospitalization. Or any exacerbations that happened in the past year. So we could, using the app, we could group the patient according to the gold group assessment, whether the patient is in group A, B, or E.
Okay, sounds good. Excellent. This is great. So now I'm trying to add this exacerbation or hospitalization.
I also have an idea for this great applications. Also
Sure.
for the symptoms, we beside the cough and the dyspnea, we can add the symptom of exacerbation like increased amount of sputum production, the virulence of sputum. So this might help in diagnosis of the exacerbation of the disease.
Yes, the cardinal symptoms.
Mm-hmm.
Very good.
Yeah.
Also, the vaccination part, we should also track it, I think. And specifically, yes.
Okay, excellent.
Or we could,
yeah, go ahead.
We could specifically like write important vaccinations like influenza and the COVID-19 and pneumococcal vaccine.
Yes. So
to track it.
Excellent. I hope it will pick up on this three vaccination, but if it doesn't specifically push or put this in place, we can add that into the prompt. Excellent. So it's gonna work on thinking about that, and it will add these features. And then one thing we can do also, because here it's adding the call for help or emergency call, we can add features like contact information or PCP, primary care doctor, so they can have the ability to print or send this log of symptoms to their family doctor. It can be sent by email, can be faxed, and then the primary doctor can look at these symptoms and then adjust the treatment plan and so on. So this is okay. And past history, like if you have hospitalization, exacerbation symptoms, vaccination. So it already added the three vaccinations that you mentioned. And then dyspnea score and shortness of breath. So save the log, supposed to save it. Yeah, let's see. So it may save it, but I don't see it displayed. So I'm gonna ask it to display the log, or we can save. So you can get the log as a PDF format file or document file or a spreadsheet like a comma separated variable file or text file. So you can add any of these. Let's see how it will display there, or how the user can view their log. So here the log is here, so it will show the data. Let's say yes. We go back here, it will show the whatever log they have. And if I want to add this feature as ability to send, it will create a button where when we look at the log, we can have the option of clicking it and save that as PDF file or text file or any other information like type of template as output. Any other features that you think maybe we can add, or
Can we add if it can recommend to contact the doctor for
yes,
the
so
patients?
we can add the doctor information and then contact information also.
I also want to add an idea, but I'm not sure if it's applicable or not. Since the major risk factor is smoking, so what about if we can apply something that can encourage them to for smoking cessation, for example, to connect them or to uh, uh, relate the number of cigarette smoking to their exercise activity, to their dyspnea, so maybe also the number of cigarette smoking smoked today, anything that can encourage the patient every day to stop smoking.
Maybe a smoking tracker or something?
Tracker, yes, maybe. I don't have an exact idea, but I think if we can encourage them through the app to decrease the number of cigarettes or to stop smoking, maybe it will be beneficial.
Sounds good. So I added some comments here from like contact information, PCT, and maybe some educational material for the patient about smoking or quitting smoking, and maybe online information or organization that also can help. Here in the US, sometimes they have 1-800 number where if you need help with quitting smoking, you call this number and then they can provide you with some free samples or some products that like patches, nicotine patch or nicotine gums or other over the counter maybe or counseling and so on. If needed, maybe they can talk to the family doctor about medications that also can help. There are different medications that are used in this area. So this is going to be version 8, working on it. Anything else that you can think about you add to this app? So again, if you want to add your information here, when I'm done with the app, finalizing it, I will put it in a different website where I can add also contributors to this app. If you want to put your name on the developer or working with this app, that would be great. If not, that's also an option. So I'm gonna just wait for the next. Yeah, go
The
ahead.
Excel sheet is not editable. We
It's
cannot
not?
edit.
Oh,
Yes,
okay.
the Excel sheet.
Okay, let's see. How can I fix that? Oh, my phone. Sorry. Can I send it again? So this is supposed to give you a option of editing. Is it working now?
Not really.
Not really. So
Do we have to get the app in the mobile phone? So because there is an option to get the app, I'm using my phone, so
uh, can I share the link again? See if that's working, and then I'm gonna update the app. So this is version 8. I'm gonna so it's gonna come in a second. So this is a output, but I'm gonna share it with you also. Basically, the latest one, and I'm gonna stop sharing, and I'm gonna give you the chat. If you have a phone or something, then try to click the app and see if it's working.
The air quality button doesn't do anything. It's non-functional.
Good. Anything else you noticed?
Yes, I actually have a couple of suggestions. For the inhaler guide, the text is very small, and for elder patients to use it, it's not that functional. If they can take out the text and make it into a video animation of how to use the inhaler, I feel like that would be better. And also the breathing exercise, it's very confusing. It just starts as a countdown. So also if that could be converted into an animation, I think that would be much more user friendly.
Excellent. So for the first one, I added it as a fix for the air quality. It will create version 9 of this app, and it will help it. The other two suggestions, Canva app is limited, so you just give it a prompt and it will write the code for basically buttons and text and links, but it doesn't have the ability to create a video and so on. If we go to the two options, one of them is ChatGPT, and the other option is Gemini. So both of them or maybe one of them can create, I think Google Gemini can create the video for you. So we can put these as suggestions for the next version, where we can add more features for all the others. Like we can increase the text size, we can do it here, but we can add also some videos about the breathing exercise, also about educational materials. It can be as a video about if you smoker, you can do this, whatever videos that you want to add. And we can create these videos from different free websites. But I think ChatGPT and there is D&D or something like that. They can create that. So there are different ways to create the videos. So it's the next layer or feature or level. But I want to show you, you can create in a group like this in a few minutes, something that can be useful for your patients, and you can modify it as you go along, and you can add some features, some you can test if there are problems, and they can fix it right away for you. So let's see if the quality, now the quality area is working. Health log is working. You can export at least some data. So anything else?
I think the medications are limited because it only mentions albuterol in the app.
Okay. So what prompt you want me to write?
Okay, so we can start with LABA or LAMA, and then is it used with in combination, or is the patient using also inhaled corticosteroids?
Also, maybe we can add the oxygen therapy if the patient is on oxygen.
Therapy. Yes.
Mm-hmm.
That's good.
I added here the ability of the user to edit these medications. So the user can add them, or if there is a list, they can pick up some of the medication, and then also add the option of like the therapy and so on, so they can either get educated or participate and so on. Did I catch your comments?
Yes, very much. Thank you.
Thanks.
Yes,
So this
thank
would
you.
be version 10, I believe. Yeah. So the next one will be version 10. We can continue testing and see if there is any error mistakes or something that's not working. We can ask it to fix it. Sometimes Canva has some limitations. So I come across some apps in the past. I created something similar to this, and for some reason it doesn't work. Even I asked several ways for the same problem. It doesn't fix the problem. So what I do is I take the output. So let's say I'm going to show you how I do it. So this is the final let's say this is the final output I got from Canva. If I right click on it and go to the frame source, it will show me the actual code. This is one way. And the other way, in the Canva itself, there's an option here to see the code while it's designed. So when it's done, I'm going to show you the other way. But this is one way. So I take this, save it as a file. And it's going to be HTML5. And I save that. And if I go to ChatGPT, for example, or ChatGPT, I can upload that file. And then fix whatever problem. Let's say, can you add a video? For example, educational video about 2 minutes long or 1 minute long. So it can ask you a few questions before it do that. So you want me to add a bit video? You can go to option 2, for example, here. So it's gonna create the video here. In the meantime, I can go back, and this is gonna be version 10 somewhere. Yes. So this is the version, the last one, version 10. So it has some more options, therapy and pulmonary rehab and so on, smoking cessation. If I go back to ChatGPT, it will create the video 1 minute. So it may take another couple of minutes to create. Anything else you think about, or any addition, any features, any problems with the website itself, like you tested it?
Yes, Dr. Nadir, I just wanted to ask if we can add anything about the CPAP, continuous positive airway pressure, like education or proper mask fitting for patient using it, or
Some educational material about CPAP.
no, about the technique, like for how long the patient should use the device a day, how many hours a day, how to properly fit the mask, and so on.
Okay. Let's give it a prompt, like, can you add educational material about the CPAP use?
Yes.
Great. Anything else you want to add? Tested that is not working.
Yes, like educational material, or for how long, for how many hours the patient should use the device a day.
So time of use, duration, and so on.
Yes.
Good. Thank you, Dr. Layla.
I have another suggestion in this area.
Yes, go ahead, Dr. Mohammed.
I feel like if I am a patient and let's say I am not on CPAP, that will be an exhaustive list of options. I might be a little bit bored of doing this application. Can we like at least categorize each set of question, like one should be the general question as a baseline for every COPD patient. And if you are somehow advanced patient, you can like go to level 2 or like to the other section of the app instead of make it all together, if you get what I mean, I guess.
Yes, I think it will be better because CBAB information will overwhelm other patients, as you said, if it's not applied to them.
Even for the other part, let's say like the patient on class A can stop at specific level, the patient on class B, or if we can just categorize the app itself. So every patient can go directly to the specific area of his or her interest instead of doing the whole question together and just not finish it because it's too long for that.
So the classifications, the goal is A, B, and E, right?
Yes.
Something like that. So maybe categorize the app so that it can, and you can display it in different ways. Some of the features most commonly used in the app, if you look at some of the apps, in the at the bottom here, you will have some icons, 4 or 5 icons. One of them is about the user, one of them about setting. If you want to, let's say this app, you want it in English and Arabic, so it's gonna be in the setting, and so on. So also we can add this as a menu or navigation menu at the bottom sometimes, or sometimes at on the top. Then they click on it, and then, for example, we have about this program, we have this website, and it lists some of the content, what we do, and some of the conferences we participate in. So it's going to be more like content stats about the conference. If you go here, you can see more about that. Videos, you can see more about that, and so on. So it's going to be like a drop-down menu. You can ask for that, or sometimes at the bottom for mobile application, for example, you can see it if you use whatever in your iPhone or your Android. At the bottom, you'll see the text or the call button or WhatsApp button or whatever browser button, if that makes sense. So you can also specifically ask for a specific design. It will organize it in face, no, page based approach, or tab, tabs, and so on. So there are different ways of designing it. So it's gonna be a user friendly, not all in one page. Like this one is, you just scroll, 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 and not every user will go over this, specifically, or especially if they are not, let's say they are not you smoker. So you don't have to ask them about smoking, how many cigarettes, and so on, if that makes sense.
Dr. Nader,
Yes, go ahead.
I have a question. I didn't get it when you use ChatGPT to create a video for you, and then how you integrate this video from ChatGPT to your app in Canvas. So do you copy the final output from ChatGPT and write it back in Canvas, or what did you do?
There are 2 options. One of them, this is the last version. Let's say this is version 11.
Mm-hmm.
So if you go here, and there is a show code. This is the code. Basically, what instructions it will give the browser to display for the user. It can display the colors, it can display the buttons, it can display the links, and so on. So
Mm-hmm.
you take this and save it in a file. To do that, you can copy all this and put it in a text file, and you name that file whatever, let's say version 10.
Mm-hmm.
The other option is to see the design and then go to a website where it will design the output for you, or let's say this is the output, and publish that. When you publish it, it's gonna be like this link. If you copy this link and put it here, or go to visit the website, it's gonna come to you here. This is the final product for you. Let's say this is what Canva created for us, right? So you can save it as web page complete. And if you do that, it's gonna be ending in the ending letters will be HTML, or you can specify that version 10 HTML. So this is COPD version 10 .html. So that just the computer or the whatever device you are using, it will know it's a file that can be read by the browser. And the browser will read this code, like what color, what buttons, and the links, and so on. So it's gonna be, and you can save it as a complete if it has some images, or can just only one page. So I'm gonna just save it as a HTML format of file. And when you go back to the ChatGPT, there is an option of when you click on the plus sign here to upload a file or a video. It will read this file and it will understand that it's a code about a web page design for a mobile app, and it will analyze. Then you can add what you want to create. Let's say I created video about educational video about smoking, and I can also see about COPD, CPAP, also a video.
Okay, so when ChatGPT create the video for me, the video will be added automatically to the website that.
No. Hold on. So this is the output of the chat that I asked. So it created the 1 minute video. There is an option of creating it in a YouTube video or Vimeo video. And this is kind of a little bit too many steps. You don't have to, there is a way, or you can go that route. It's an option, but the easier option is to use, for example, generate 1 minute, and it's gonna come out as a video, like an image for you. You can just download that video. So it's an option to share. And here you can download that file, or you can copy it as a link. So it's gonna be saved and as public. You can share it with others. But let's say I'm gonna download it and you can put it in your YouTube. That's another option. So it's gonna be like a 3 steps. The easiest step is to copy the link and then go back to Canva and add this educational video link. And you give the link. So when you give the link, it will show it as a clickable so icon like this. When you click on it, it will go to this site here. So you click on it, it's gonna be what's supposed to work somehow. Let's see. So it created just the image, but the video itself can be created. Let's say it creates the video and you can download that and then share the video with the campus. Now it's version 12 and it's added somewhere the gold classification, setup profile, and it's supposed to be somewhere here, the link for the, okay. I don't know where I put it, but so new tab, sliding direct links, video. So it added somewhere. So if you are a smoker, maybe it helps. Don't know. So it will add it if it didn't, but
Okay,
you
okay, got
you
it.
have the idea. Yeah.
Yes, yes, I got it. Thank you. Thank you for the extra explanation. Thank you.
Thanks. Any other questions and any other comments, suggestions? If not, I'd like
Can
to.
we just
Yes,
have
go
the
ahead.
link? Can we have the link for the application? The final version.
Oh, number 10. Okay, let me.
Yes.
Number 12 now. So let's see if this is it. And name the website address. It's going to be the same.
One more thing, property,
So you can name it whatever. Let's say COPD 12, for example. So I'm gonna publish it as COPD 12. This is version 12. And I'm gonna share the link with you in a second. So copy the link and so I added to the chat. Excellent. Any other questions, comments? So as you see, it's not going to take you long to develop an app working and maybe with some glitches here there. But you can add, modify, improve, and share that link with others. There are some limitations when you create the app as far as is it engaging, but I have for the as a boxer. I use it to create division material, videos, and so on, or you can find some links to help patients similarly. So you just think about the first step. It's easy, you can do it, and then you can add more features as you go along, version 2, version 3, and so on, depending on what you want to add as features or what you want to fix as problems or glitches or bugs in the app. And then you can test it with your friends, family, other fellows, and so on. And you can publish it. And in some situation, you can add it as a source for income if you want to sell it as a product that can be used by some people. But for this level, at this point in your life, I think you just think about your patients and you can just create some simple app to help them as far as logging information, contacting their family doctor, improving their health quality of life, and also keep them out of the hospital, for example, congestive heart failure patients. So you can do the same step that we did for COPD. We can apply the same concept to patients with congestive heart failure. And you can put that in your resume. You can talk about that in your interviews. And hopefully, eventually, you will use it in your real patients. Any questions, any comments?
Hello, Dr. Nader. I don't know what is the problem, but it's not open to me, the app. I don't know. I tried to open it, not come. I don't know if there is anyone face the same problem or just me.
You can just add the application to the home screen, and then it would automatically appear.
Okay, thank you, doctor. Thank you, Dr. Einas. Dr. Nader, you are mute.
Sorry about that. So I just added it to the link to the app itself. So the agenda for today's meeting. If you come across in the future, you will have the COPD app link. Hopefully, is it working now? The link. Okay. Thank you so much. Any other questions, comments, ideas? And you can use it also in your WhatsApp group, the big group, if you want to share it and see if people can test it and see if they want to add more features, more ideas, and we can work on getting that done, improved, and hopefully can be used with some of the patients who have COPD. All right, with that, I think we can come to conclusion, and I'd like to thank you all for great presentations, for the presenters, Dr. Malaz and your team. Thank you so much, everyone who attended today's meeting and those who will come and watch the recording in the future. Please let me know if it can be of any help. You can reach me, send me a text or email, WhatsApp, and we'll be happy to
Thank you,
help.
Dr. Nader.
Thank you, Dr. Azak. Thank you all. We'll see you next week. Assalamu alaikum.
Alaikum salam. Thank you.
Thank you, Dr. Nader.
You're welcome.
Thank you very much, Dr. Nader.
Anytime. Thank you so much.
Thank you, Dr. Nader.
Anytime, Dr. Azak.